Hello, everyone. I want to thank Mark for having me be part of this group. It's been really fun. This is a great location. I've really enjoyed everybody's talks. And in fact, several of you have talked about trauma and stress. And Dr. Lustig has already started to talk about stress in the brain and its relevance to food and food circuitry, so that's been very helpful. So hopefully I see my time there, I will get going on this. So just as introduction, I wanted to focus in on overeating, binge eating, and obesity. And binge eating disorder, just very quickly, insufficient restraint, chaotic eating, strongly associated with obesity. And then obesity, as you've heard, very simply excessive energy intake or with lower energy expenditure, sort of is the perfect storm, so to speak. So just very quickly, what about the behavioral approaches? If you look at, there have been numerous trials of CBT and behavior therapies, well-established treatment for binge eating and obesity. 50% of people will remit, but no weight loss. So there's been this really interesting thing in the literature that cognitive behavioral therapies work and behavioral therapies work, but weight loss is not there related to that. There are alternative therapies. You heard some about that, interpersonal therapy and DBT. And again, weight loss is pretty minimal. CBT is superior to pharmacotherapy. So there's this marked disconnect between reductions in binge eating. You can get people to reduce binge eating, but again, minimal weight change. And then here is the big thing that several of you have talked about, which is you can get people to drop weight with doing physical activity, nutrition, some of the standard lifestyle interventions that people are given in terms of recommendations. But the rub is really in terms of what we in addictions have called for long-time relapse and high rates of relapse. And this is true with weight gain as well. And what you see here is a really nice sort of graph of one-year outcomes for in terms of relapse. How many people go back to doing the drug? And these numbers are really, difficult and dreadful. And it was sort of, in my career, as I started off doing the science behind addictions, this is what was sort of staring in my face. I was running a large addictions program at Yale, and we had committed patients working their recovery, and they'd come back and say, I don't know what happened to me, doc. I was out there, I was facing life, and boom. And so what our interest was to let's bring, what is happening out there? Can I bring that into the laboratory? I want to understand the mechanisms to change and improve our treatments. And that's really what we're doing even with food and with overeating and obesity. So let's just acknowledge, I mean, it's amazing. Our chefs and our companies and people have just done an amazing job. There's delicious foods out there, right? I mean, it's just temptation abounds in every corner. We are faced with this. You put it in your mouth. It's stimulating the reward pathways. You've heard about that. And it's not just that it's tempting and stimulating and it's delicious. In the US, I think the amount of sugars and flavors that support this kind of temptation is used more. Anybody who's been having some desserts in Europe versus here, try to taste the sugar content. I mean, it's really pretty interesting. There's a difference in some of the recipes. So we just take in more. Perhaps our baselines have shifted. So there is a real power to food and food cues. But I want to take a step back and just put the focus on what else is going on. And there seems to be something missing. Okay, here we go. So we have also begun to very carefully and systematically study stressors. It's not just today I feel stressed. That comes and goes. It's a very dynamic thing in terms of how much tension and anxiety you may feel in the moment. There's also a history we bring in our lives, and unfortunately, trauma, violence, interpersonal conflicts, divorce, these things are very common, and I say that meaning that our lives can be faced with all kinds of stresses, but also it's really where we are in society today. You've got multiple things going on, and so we need to sort of find a way of what's the exposure level. And one of the things we've been doing at the Yale Stress Center is really, can we come up with a stress load index? And we're actually going along with really characterizing that stress load index. And there's a way of sort of getting account of the first three categories, which is major life events, life traumas, recent life events, really just getting the number of events in a very systematic way. And then chronic stresses are really your subjective response to stress. That's the perceived stress that people talk about. But in our model, that's only one component, because the other things are like hits. And in the interest of time, I'm not showing you the figures, but this is published data of what do these hits do to the brain. We actually have reductions in brain volume in critical regions like the prefrontal cortex, the ventral striatum, the reward regions, the insula, that's related to how many hits you've had. And I call these hits because this is repeated stressors, okay? How many times did you get knocked down? We get right back up. We're wired to be adapters, okay? We adapt. We've got this whole frontal part of our brain to help us adapt, and yet that's the most recent part of the brain evolutionarily, and guess what? It takes the biggest hit because it's just not as well set up. So just moving back to obesity and stress, the link here's a stepped up relationship right there in a large community sample. The more my y-axis is missing. Well, so on the y-axis, those numbers are actual total stress. So the number of hits you've had and the number that score on your cumulative interview is directly related to BMI. So we've heard a lot about brain reward circuitry, and that's very important to sort of keep in mind. Here are high-calorie foods and food cues. They stimulate the hypothalamus, marked there as HYP. And then the NAC-VTA, this is part of the reward pathways that you all have been hearing about. And then the prefrontal cortex, the PFC. This is our decision-making, our regions of the brain. It's involved in monitoring. It's involved in planning, problem-solving. I just told you that it's dramatically affected by stress. So this is the reward pathway. I shudder a little bit when I hear the words reward pathway, because actually it's our learning pathway. It's a learning and motivation pathway. It's very, very intricately involved in stress. If you were faced with a tiger, you actually need the system. You need to get up and run and save yourself and hope it gets somebody else before it gets you, kind of thing, because then it'll get diverted. Not that you want to do that, but so it's your motivation pathways, and I want to broaden your thinking about the reward pathway because they're completely responding to the stress pathway. And now here's your stress pathway. Can anybody tell me where the differences are between the two? There are some differences, but as I'm marking those out here, it's the same highly overlapping pathway, okay? So the question is, when you are faced with stressors, how come some people want to avoid things and others want to approach their rewarding substances? So we've been very taken up with looking at stress-related approach behaviors and motivated behaviors, and what in this circuitry goes awry when you're faced with foods, highly rewarding foods and sugars, and then how does spikes in glucose actually lead to adaptations in this circuitry and affect your ability to face stressors and break that cycle of stress-related eating. So here's some data where we gave, with Bob Sherwin at Yale, who's an endocrinologist, we gave people glucose. And glucose will basically decrease activation in healthy, lean individuals. This is healthy, lean individuals. It'll decrease hypothalamic activity. And there's a nice connection between hypothalamus and the reward pathways, which is connectivity down here. So the hypothalamus signals the reward pathway, and once you get glucose on board, everything chills out and things go down, and there's that nice relationship. It's unpublished data, but we actually now have data in obese adolescents and obese adults. The pattern is completely reversed. There is no chilling out going on over there. Okay, so it's actually yellow and red in the hypothalamus and the striatum. Here's published data from food cue and stress cues, which we expose people to, both food cue, favorite food cues, and stress. And here, look at the similarity in terms of the regions that are related to food cue-induced craving and stress-induced craving. So the motivational pathways are activated. and move right along to promote eating behavior. The thing I want to underscore, which goes along with Dr. Lustig's talk, I think, quite nicely, is that this is not happening on its own. Insulin, leptin, and the metabolic factors are major players in signaling the brain. So dysfunction or dysregulation of insulin, insulin resistance, leptin resistance is actually activating these regions and promoting food craving under food cue conditions. And look at what's happening in the lean folks. It's completely the opposite. There is no promotion over there. They're exposed to food cues as well. Their hormonal levels, insulin levels are normal, and in fact, there is no potentiation of reward. So the story gets a little bit more complicated, and clearly, as you have weight-related adaptations in metabolism, there are also concomitant adaptations in the brain, and you're dealing with more of the disease state that people have been talking about. This was a fun study where we wanted to look at glucose, and we manipulated glucose levels. So it's mild hypoglycemia, and as we manipulated glucose levels, we showed people pictures of nice foods like those ice cream cones and brownies and chocolate chip cookies, but also tofu and broccoli and carrots and then some tables and chairs. And then you had to rate your liking and wanting. We wanted to see how the brain responds, the food preference and craving changes as a function of glucose changes. And when glucose dropped on the left there, on the right there, you can see that under hypoglycemia, cortisol levels go up. So this is my point about how closely tied the changes in metabolism or changes in glucose and peripheral changes can affect the stress pathways. So what happens in the brain? Well, everything in blue there is what goes up when you're mildly hypoglycemic or glucose levels are down. You've skipped breakfast 6 hours, glucose levels are mildly down, there are no symptoms. So there again, everything in blue there is your reward and emotional pathways, and it's increasing motivation. The brain is signaling, let's go get some food. But guess what? Not any food. The thing people are craving are the high-calorie foods, all right? So here's a biological signal. This is not about, oh, this would be good. Right there, glucose is dropping, and you're getting an increase to replenish the high-caloric foods. And in fact, drops in glucose correlates with the prefrontal cortex, our decision-making areas, and so any drop there will take the prefrontal cortex offline, and then cortisol is pushing up insulin and striatum. So does this greater understanding of mechanisms driving excessive food intake open new treatment avenues? That's the critical question. We love to get these brain pictures, but does that tell us anything in terms of where to go from here? This is actually data from addiction, not obese individuals, but just to give you a sense of where we are headed, we are using this drug called guanfacine, an alpha-2 adrenergic agonist, which has been approved for attention deficit hyperactivity disorder. One version of it. It's a long-acting version that has been approved for ADHD. So we know it actually brings back prefrontal cortex. So a lot of you have talked about prefrontal cortex. So what about bringing back the prefrontal cortex? Making people more front-loading decision-making, front-loading better planning. That's one of the things we're trying in addiction. We're applying it to obesity. And here are some data just from cocaine-dependent individuals. Our data from in obesity are still forthcoming. We did, and this was our first foray into looking at mindfulness, targeting food cravings, and you see with an 8-week program, depression scores are down, perceived stress scores, blood pressure is improved, food craving is improved. We now have a randomized trial, pilot trial, where we extended the 8 weeks because 8 weeks was just not enough. So we extended it, and we now have data with 12 and 16 weeks where body weight is down, and it's a more comprehensive program there. It's not only mindfulness. And so let me tell you a little bit about what we're doing in our clinical services. We have an evaluation and follow-up visit with an endocrinologist because we believe, and I think you've seen data, that in fact changes related to weight gain happen much earlier in terms of your metabolic hormones than the physical health complications, meaning changes in glucose, in insulin sensitivity happens earlier. And in fact, you might need some help from your from the endocrinologist around some therapeutic advantages there. Of course, nutrition evaluation and guidance, physical activity. You heard about the pedometer. We use that. Stress is a very critical component of our weight management program because of hopefully the little bit that I've shown you, and so we target that. That's part of our program, and then we have group and individual sessions as well. So I will stop there and still have 2 minutes if somebody has questions. You're moving along, right?